So I'll get cracking the map because we're up to about 30, so there'll be more coming. So good evening, everyone, and welcome to another BOMSS webinar. Before we get started, I'd just like to mention that the next Journal Club will be on the 12th of April, and the next webinar is scheduled for the 26th of April, and details will be coming out from BOMSS about those in due course. But tonight we're very grateful to Mr. Matt Venus, who's a substantive surgeon up in Warwickshire, been there for 9 years and been clinical lead for some 6. And he has a significant sized NHS practice, which is very nice to hear, as well as some private practice up there. And he tells me that his first day on the job when he arrived in his substantive post was actually going to the bariatric MDT. So a wealth of experience, and we look forward to hearing from you tonight, Matt, on your thoughts on body contouring. So over to you.
Lovely, thank you very much. I'll just share my screen and we'll get going. Okay.
And yeah, we've got your screen.
Brilliant. So yes, thank you very much to everybody for joining this evening. It's a pleasure and a privilege to be invited to talk to you all. I hope this will be an interesting and informative talk. There are quite a lot of slides, but a lot of them are just photographs. And there are some intra-operative photos for the squeamish amongst you, just to warn you. But yes, so I'll start. So skin excess after massive weight loss, managing the abdomen. So these are all my patients, except where I've referenced papers. So please don't show the images outside the presentation. Patients have given consent for me to use their pictures. So I thought this evening we'd talk a little bit about the patients and selection, look at the distribution of the excess skin in the trunk and the abdomen, and then using some case examples, look at the type of procedures that I use in order to try to remove the excess skin that patients develop after the weight loss, and then touch on complications at the end. So what is body contouring? So for those who don't know, it's really reconstructive surgery following massive weight loss. It's not always cosmetic surgery. I look at this as very functional surgery. I've had 2 patients independently refer to their abdominal apron as their clap flap, because every time they go for a run, it gives them a round of applause. And so this pretty horrible thing, obviously, to have to live with. And so I view this very much as functional surgery. And I think the patients often view it as such as well, because they're very accepting of the potential risks and the enormous scars that they have after the procedures. So my general impressions, really, I've been doing this for about 10 years now, and almost without exception, the patients are lovely. Their expectations are realistic, and they do tolerate what we put them through very, very well. There's complications and also the need for revisions, which are unfortunately quite common. But you know, they are very accepting of that. And I noticed their skin really isn't normal. It's been stretched in a way that makes it damaged, in inverted commas, and it sort of relaxes a bit more after surgery. So there is that sort of Goldilocks amount to remove, not too much, not too little, just enough. So I tend to slightly overdo things because their skin does tend to relax afterwards, and try and avoid those revisions. I'm aware of, you know, we're all aware that high body mass index does relate to increased chance of complications, but some of these patients, as you know, have extremely high BMIs to start with, and trying to get them to a BMI of less than 30 is impossible. So I try not to let it stop me trying to help, but I am cautious in the surgery that I do, and I try not to overdo it, particularly patients over BMI 35. We're very lucky in Warwickshire, in Coventry, where I work, that our CCG now, our integrated care boards, do allow us some flexibility in treating patients with a BMI over 30s. The rules are not so strict. So I have operated on patients for apronectomies, most recently a BMI of 74, although that's not normal. Usually patients are around 30 to 35. And clearly patients come along with comorbidities. Diabetes, again, another high risk factor for complications, but it's certainly not a barrier to having surgery, particularly if the diabetes is well controlled. Always very nervous about previous abdominal scars, not laparoscopic, but large old-fashioned cocker scars from cholecystectomies and things, because that can affect the blood supply to the skin, and it limits a little bit about what we can do. Hernias are very common, I've found, and they're not always very easy to detect, particularly if the patient's still carrying some weight. So I have quite a low threshold for CT scanning, and of course involve a colleague if necessary to do some joint operations. I've done quite a lot with Vinod Menon, where we approach the hernia together, and he kindly repairs it, and then I carry on and remove the skin or do whatever I'm planning to do. And as I said before, got to be cautious not to overdo it. Patients aren't looking for cosmetic perfection, and I think that's probably impossible to achieve. So everything is just so. So you can address lots of different areas. These are some of my patients from the past, but this talk is really going to concentrate on the abdomen. So this is a cosmetic patient. This is certainly not a weight loss patient, and often tummy tucks. This is what people think about, tummy tucks. A little bit of a paunch, bit of abdominal laxity, looking really to try to improve the contour. But of course, the normal sort of patient is a little bit more like this, with ptosis, the breasts and the abdominal tissue. You can see a para-umbilical hernia, and of course the laxity of the abdominal wall. So this patient, definitely has a BMI of about 33, 34. So very different kettle of fish. When you sort of think about the way that the skin changes with weight loss, a bit like a lampshade that's melting on the frame, where the skin is the lampshade and the metal frame is the fascia and the skeleton that usually holds our skin up. And so the patients often have quite a predictable distribution of excess skin when they lose their weight. And these are sort of the deformities that we look at when you analyze and assess a patient. So I look for where the excess is. Is it above or below the umbilicus? Is it in a vertical or horizontal direction? And is it at the front and the back and the flanks? And all of these then putting together with how much abdominal muscular aponeurotic laxity they have and how much excess fat they have, sort of starts to help you decide with the patient what the best procedure might be to try to get them where they want to be. So those are the things I look at. I look at skin, fat, and muscle weakness, as well as hernias. And then the options are excise it, tighten up the muscles, resuspend the fascia so it doesn't descend, and then maybe in brackets at the bottom, the last two, liposuction and fat transfer. I don't really do any fat transfer, but it is described to try to augment some areas and reduce others. But liposuction I'm a bit nervous of, particularly in the weight loss patients, because of occult hernias. And the last thing I want to do is to turn someone's hernia into a columbus and cause trouble. So I tend to limit the amount of liposuction that I do. And as I say, the decision making is really in which direction is the skin in excess and where is it? But also treating them in the context of what their concerns and priorities are in terms of what they want to achieve and also how much they want to go through. So some of the operations take 2 hours, but the biggest operations take up to 5 hours. So that obviously has a bearing on recovery, downtime, and of course, amount of scarring. So broadly speaking, these are the procedure types. There are abdominoplasty, which really addresses the lower abdominal skin below the belly button. It has a tightening effect on the skin above the belly button, but the reduction really in skin is really all infraumbilical. The fleur-de-lis, which translates as flower of the lily, describes the excision pattern, which originally involved an vertical excision of the pubic mound, but I don't do that. I don't think that really helps very much. So that's the fleur-de-lis, and that helps to excise skin in both the horizontal and the vertical direction. And then, of course, all the way around, circumferential, so-called belt lipectomy, to help reduce the excess in the flank and the backs. And you get a free buttock lift with that operation usually, pardon me. And I also combine that with a fleur-de-lis. I call it the fleur de cercle. You start with the patient on the front, take the excess off at the back, turn the patient over, and then do a fleur-de-lis after that. And that's a really, really powerful operation. So just, plastic surgeons can't really work without lines. So we do lots and lots of markings for these procedures. So here's an example of how I would mark a patient for an abdominoplasty. So I look at where the natural skin crease is, and I mark that with the patient standing up. You have to be quite careful in these patients. If you restrict your lower incision to where their natural skin line is, often you can leave quite a lot of the pubic mound redundancy behind, and you end up with a ptotic, droopy pubic mound afterwards, which they don't like. And so what I do is I lift up the skin, and I'm to mimic a Mons lift, measure about 7 to 8 centimeters from the vulval commissure, and that's where my inferior incision is, and that helps to lift up the mound. And I find that if patients don't often mention their ptotic pubic mound, except the men tend to, the women don't. But if you point it out, they go, oh yeah, I don't like that. If you can sort that out as well, that'd be really helpful. So I include that Mons lift in the procedure just to try and set the lower abdominal incision and lift up that pubic mound. Measure 6 centimeters either side of that point, and then again mimic the excision by pulling superiorly medially, and then join the 6 centimeter line to that line I marked previously at the corner, and that's my markings. I estimate how much I'm going to take out superiorly, but never commit to that incision before I know I can get the wound together. And that's assisted by the dissection, which goes right up to the xiphisternum, and then flexing the patient while they're on the operating table to try to get as much out as possible without overdoing it. So divarication, or widening of the aponeurosis between the rectus and abdominis muscles, is really common. In fact, it's probably ubiquitous. And this is a photo in surgery, and you can see the bulge that the patient has where the rectus muscles are separated. And I find the best way to demonstrate that is to pull up with a Morris retractor, and it really shows you where the edges of the rectus muscle are, and that's what you need to stitch back together again. So that's what I'm going to repair. And what I do is take a #1 loop nylon, centimeter by centimeter apart, lock it as we go. When it gets to the belly button, you don't want to strangle that, so you come down one side and then keep going. That gives you a nice flat foundation for your skin reduction, which you put on top again. As I say, try not to strangle the belly button and bring the muscle edges together. We can support the Mons lift with a little 3/0 vicryl. I try not to pinch the Mons. You sometimes see post-op photos, you might see some later from an American journal. The Mons that's really pinched, I try to peg it out and flatten it so it has a nice takeoff at the inferior part of the abdomen. And sometimes the patient's got a really long umbilical stalk, so I just stabilize that with some 3/0 vicryl just to keep it where I want it. Now, this is the bit that hurts. It's the repair of that muscle, sutures going through the fascia, is what I find limits the patient's initial recovery, certainly for the first 24 hours. So over the years, myself and my anaesthetist, Dr. Vidyanath, have developed sort of a set of injections that we find really help. I've tried indwelling catheters, all sorts of things. This I find works really well. So you take either a dilute solution of 4% chloracaine, whatever the maximum dose is, mixed with saline to get a really dilute solution. And I inject about 1/3 of that into the rectus fascia in lots of injections with an orange needle, sort of segmentally inject it, and then take a blunt needle and do tap blocks, bilateral tap blocks, to try and flood the neurovascular plane with anesthetic. And more recently, I've been using ropivacaine, which comes in a big 120 ml bag, and that's fantastic. You can use that 40 mils, and they're virtually painless afterwards. They're comfortable, they can cough, they can move, and I think it helps just to reduce the chance of, of chest infections and the like. So towards the end of the procedure, flex the patient, remove the skin. I try not to use drains. I don't like drains. Patients don't like drains, so I stitch the abdominal apron down, quilting with some PDS, bring the umbilicus out in its natural position, stitch everything back together again. So here's just the case example. The lady has had 3 children, lost some weight, BMI 27. She's got that characteristic round appearance to her abdomen, with some abdominal weakness, some excess fat, and a moderate abdominal apron. So I did do liposuction, it's one of the exceptions, but I did do liposuction, 400 mils, and I sort of make an estimate about how much fluid I want to put in. That's how much I got out, about 1,100 mils. That's fat and infiltration fluid, it's not just fat. And I took off 2 kilograms, just over 2 kilograms of skin from her abdomen. And that's left her with a much flatter appearance, low scar, which are usually uneven, and I consent them for uneven scars, which tend to settle. This is taken at 3 months, tend to settle really quite nicely down. It's got a little dog ear, I think, there, a little overhang of skin, which we'll talk about later. So thirdly, in the context of massive weight loss, is probably one of the most common procedures I use. I think it's brilliant. It's really, really powerful. because it corrects the excess skin in two directions, vertically and horizontally. And as I said, it can be combined with a circumferential lift. Again, low threshold for CT scanning. So here's a gentleman who'd lost 12 stone from memory. And again, one of his major issues with this enormous ptotic mons area here, and he couldn't stand to pee, he had to sit down to go to the loo. So he's really keen to try to remove as much skin as possible. And this is why it's called a fleur. This is another patient. This is why it's called a fleur de lis, because this is the excision pattern you get. You get a lower abdominal ellipse removed, a vertical ellipse, and it looks like this, fleur de lis. So repaired the divarication. I've actually done some lateral plication, transverse plication as well, and closed it over a drain, stitched the belly button into the scar. And that's why you get this big inverted T scar. So here's our man, about 3 months post-op, enormous scar, but much, much better, much more functional, and he can get on with his life. And although the scars look very red initially, a year later, after I've done his chest procedure, you can see the scars fade really very nicely, and he's managed to maintain that result very well. So circumferential procedures, sometimes you have patients who've had their abdomen treated elsewhere and come just to have the back, so we call that a posterior torsoplasty, but it can be safely combined with an anterior or a fleur de lis procedure. So this lady's got excess circumferential skin, as you can see, and these are the markings. Excuse me. You take a pinch at the back, always get a little bit more out laterally than you do medially, and I sort of make these little markings. So we're going to take out the back first and leave two massive standing cones, two big dog ears, when we operate with her on the front, turn her onto back, and then do the excision on the front. So these are excision specimens from the right side of the back, left side of the back, central abdomen part fleur de lis, and left and right sides of the abdomen with the weights here. So 4.7 kilograms of skin removed from this lady, which is considerable. And this is her afterwards, again with these long scars, asymmetrical again, but it obviously took a bit more out from one side than the other. And I hold my hands up always to patients and say, look, this is just how it is. You get these asymmetric scars. Sometimes they're high, sometimes they're low. And they're very forgiving of me, maybe, or maybe of the procedure because of this. Okay, massive aprons. So sometimes patients turn up a little bit like this. I'm sure you've seen these patients, and you can see that my photography is not angled because the curtain is hanging straight. She's actually leaning backwards because she has this counterweight anteriorly, which she's trying to work against. It's so enormous. The patients often have this enormous lymphodematous, ulcerated appearance with sometimes with multiple infections. So clearly an abdominoplasty type procedure really isn't what we're after here. This is very functional surgery. It's an amputation operation, a melon slice apronectomy as it's called. The patient will lose her belly button. Basically, we're going to make a cut from one side to the other in an efficient and speedy way to limit her anaesthetic risk. So these patients usually have a high BMI, close discussion with my colleagues in anaesthesia. And they usually book an HDU or an ITU bed to be available just in case. There are large shifts in volume. So the way that it sort of worked out, I've done 4 cases like this now in the last 10 years. It's a steady dissection, careful clipping of the vessels, which I call the machine gun technique, with using the automatic Liger clip, click, 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 put loads of clips on and just let everything try and sort of settle as we go. So here's another patient, it's not this lady. The patient's head is to the left of the photo, feet to the right, and you can see the apron on incised across the abdomen. And you can see the size of the blood vessels are absolutely enormous. So you've got to be really, really, really careful that these clips do not fall off post-operatively because they could bleed extensively and very quickly. So I put lots and lots of Liger clips on as we progress through the section. So this is my lady, 31.8 kilograms of apron removed. And this is another patient again, excuse me. But this is what I've tended to do is not close the skin because there's a really high chance the skin's gonna fall apart. So what I do is I put some stitches in the fascia just to oppose everything, widely spaced skin clips, and then put a topical negative pressure or vac dressing on and just keep them in for a week. And I take the patient. What we may do in a week's time is take you back to theatre, just stitch the wound up. But what I found is actually they just heal. They heal with this topical negative pressure, they go home with it, usually for another week, leave the calypsin for 3 weeks, and they heal up. So this patient can now get on with her life a bit better. So this is actually the first patient I showed you who's leaning backwards. She can stand up straight, and she can go and see my colleagues in bariatric surgery for a bariatric procedure to help her lose the remaining weight. Okay, complications. So lots of complications. This is from a paper I quite like, actually. It's got quite a good example of how the starting BMI really influences the outcomes. And you can see the top 3 pictures of the pre-ops and the bottom 3 pictures of the post-ops. So there's patients who have high BMIs to start with, don't have great outcomes cosmetically post-operatively. Everything looks really rather pinched, there's lots of excess skin left. So if you don't start with a good BMI, you don't usually end up with a great cosmetic outcome, although it's not about cosmesis, of course, all the time. BMI 30-35, better result. Less than 30, fantastic. You're always going to get a good result, really, with starting with a very low, much low BMI. So patients come and they are fully deflated with absolutely no fat and only skin. They usually end up with a really, really very nice result. These are sort of things I warn patients about. Complications are many and varied. I don't expect you to read all of that, just to illustrate really, how much can go wrong with these operations. Certainly in my experience, seromas, collections of fluid under the skin are very common, delayed wound healing certainly. And then little revision operations to remove excess folds of skin, or even coming back to revise parts of a fleur-de-lis, for example, are relatively common. There's one of my patients with wound breakdown, and this is very disappointing. This happens obviously, tend to treat them with topical negative pressure, and over 2, 3, 4 weeks sometimes. Usually they heal in really with very reasonable scarring. And then minor problems like dog ears, so-called dog ears, which we could just excise under a local anaesthetic in clinic or treatment environment. So I realised I rattled through that rather more quickly than I thought I would do, actually. Cosmetic surgery is very functional surgery. Patients often present with infections and ulcerations within the folds of the excess skin that they have, and they find it difficult to function in society. They don't like to go to the swimming pool with their children or grandchildren. Even things can be a real problem. So, the WHO definition of health includes mental and social well-being as well as physical. And I think that these patients are very deserving of the opportunity to access that state of health. So we know 90% of patients presenting with bariatric surgery have body image issues. Their bariatric surgery really just gives them another reason not to like themselves because of the massive amounts of excess skin. It's also been shown that patients are more likely to regain weight if they don't have body contouring after bariatric surgery, and they are happier on several measures: body image, sex, greater quality of life, and even career progression. So I'm a big advocate, not just because I like doing the surgery, but I think it really, really does help the patients at the end of their journey, after they've had bariatric surgery and have changed their diet and the way they live their lives, to then have the excess skin removed. I think it really is the cherry on the cake. So thank you very much for listening. I hope that was interesting, and I'd welcome any questions that you might have.
Thank you very much indeed, Matt. That was a fascinating insight on what you've been up to over the years. And what I forgot to say at the beginning, because I thought you're all experts now, and thank you for Amy for kicking off. Please post your questions in the Q&A box. Amy's off first. She says, are patients with a BMI of greater than 35 advised to lose a certain amount of weight in any time frame for skin removal, and what frame is often recommended? And she's got a patient who's been advised to lose 2 stone in 3 months to qualify for surgery.
Yeah, so I don't give patients time frames. I think that's a little bit unfair in some respects, because I think 90% of the time you're going to be very disappointed. What I try to do is, even if I know patients don't qualify, even if they're coming to that point where they've lost some weight but not everything, I'll see them in clinic and I'll just talk to them about what it involves and the reasons why I really need the BMI to be lower. And then I usually say, up to you. there's no, I don't give them a follow-up appointment or whatever. I just say, when you reach your target, when you reach that goal, come back and see me. So I don't apply a time frame.
Thanks. Do you want to unshare your screen, Matt? So yeah, Emma, great question. So I think those you didn't hear, Matt's area, he's almost got a carte blanche to operate from his ICG board. And a lot of us around the country struggle. So Emma has asked, is there anything we could be doing as a collective to encourage funding for excess skin removal and equity of funding across the country?
Wow, that's a big question, I think. I think the answer is obviously not very easy. I think we've been trying. One of the things that I find frustrating is that part of our the rules for us is that the patient has to have had a starting BMI of 45 or more. And so if they're in at 44, 43, they've still got all of the problems of the patients who do qualify, and yet they don't qualify. And I think that's very unfair. So I think we can only really try and use the evidence, and there is really good evidence out there that doing this work really, really helps the patients. And it should be part of that bariatric treatment sort of package, if you like.
Is it something that's being pushed in your society nationally?
I don't know, to be honest. I don't know.
All right, thank you. Do you ever estimate the amount of weight in the excess skin? We have a patient who's gone from BMI 80 to 60 and is still being asked to lose weight. So, it's when you see someone in clinic and go, oh, they must have at least 20, 30 kilos there. That would make their real BMI X, and therefore they qualify. Can you estimate weight like that?
No, I don't actually. No, I haven't been in that situation. Maybe that's why I haven't had to do that. And we have to do that. Sometimes we do that for breast reduction patients. And whom you say, well, actually, yeah, their BMI is high, but that's because they've got double K breasts, that's the reason their BMI is high. But I haven't had to do that for the bariatric patients.
Jim's obviously back in the country, or maybe not. With a massive apron, I was going to ask as well, Jim. Good questions. You gave a description of the melon slice apronectomy, and then said handed on to your bariatric colleagues. We do see these patients with both high BMI and massive apron. And as Jim says, how do you decide between the order? Is it always apron first? Do you mind having to do it twice, or would you rather the weight loss first?
I think it's patient to patient. I would never say always or never, really. It depends on the patient. So the patients who I have done the melon slice have come because they're in a position where their apron's down by their knees, and just getting that apron away will really help them to then progress with the bariatric surgery and the weight loss as a whole, because it doesn't make sense to wait. And if they come back with an enormous scar I've made having lost loads of weight, well, I'm just going to cut that scar out anyway. That's not going to change what I do in the future. I can still do abdominal procedures having done that apronectomy first before the bariatric surgery.
Okay. Rajab, your question about eligibility for NHS treatment, it varies according to ICB boards across the country. So it's probably a bit too much of a question to answer in this format tonight, and you have to go through your own ICGs. I know down in Hampshire where we are, it's starting BMI 50 and you have to get to 30. Nicola's asked, does dry body brushing pre-surgery assist in skin turgle?
Wow, I don't know what dry body brushing is. I'd be interested to know what that is. But I think, as I said, the skin is damaged in the weight gain, and then in the rapid weight loss after bariatric surgery. So I don't think so. I don't think there are any proven benefits to help that, really. As I say, if you excise the skin so it looks all right on the operating table, usually it's loose within a week or two. So you do have to put a bit of tension in the wound, not so much that it falls apart, but a bit of tension. And I found that is good enough. And still, patients come with loose skin in areas that I've treated. You could go on forever. You sometimes feel you could do 3, 4, 5 operations, and you still have a lot of loose, sometimes areas of loose skin. So I haven't found anything that helps that.
Thank you. Amy, again, do you follow any nutritional screening of patients prior to skin removal for patients post-bariatric surgery?
Yeah,
Great
so
question.
not routinely, because the bariatric team in Coventry do that so well. So, I mean, if their albumin is ridiculously low, or they have dietary or nutritional problems, then you have to think very carefully about doing surgery for them, because the wound's not going to heal very well. But I don't make it a line in the sand. I think I'm quite a reasonable person, and I think the patients are reasonable people, and without wanting I don't want to perform surgery where I know there's definitely going to be an issue, because I don't want problems. But I think you have to be commonsensical about it. All these things are not completely correct. We can't have all your patients BMI 25 perfectly nutritionally, on it. There's going to be a spectrum of these issues.
Smokers?
Smoking is a line in the sand for me, and I will not operate on smokers.
Good to hear. And we've got time for a few more questions. So if you've got, I didn't scroll down enough. Thank you, Emma. Do you assess for body dysmorphia disorder in patients who return for further plastic surgery, or how would you manage a patient if you had concerns regarding this?
Yeah, this is a really interesting question, actually, particularly from medical legal points of view and our indemnity, where we are expected to have some kind of assessment for BDD, which is quite difficult because the assessments are not straightforward questionnaires. They are complicated often, and need experts to interpret the results. So, in our plastic surgery training, part of our training is in trying to look for patients who have unrealistic expectations, which might be a sign of body dysmorphobia. So if they do return, I think you have to sort of look at the reasons why they're returning. Most patients, as you've seen, have very obvious problems that you can easily relate to, and you can see how helping them would help. But if they were to return with slightly unusual requests, or in requests that you think that there might be something strange going on, then I'd ask Emma to have a look.
I think combine a question here. So yeah, I was going to ask around this as well. So obviously there is variation according to access across the country, and a number of patients are now going overseas for medical tourism. So two-part, do you have problems with complications coming back from overseas? And also in trying to counsel and discuss with patients prior to perhaps traveling, do you have any tips or suggestions about how to counsel people about who may be at more risk of significant skin issues?
Yeah, so definitely we've had people come back, not usually post-bariatric. Well, they did see a patient today who had an augmentation mastopexy in Poland in December and ended up with an exposed breast implant. But to be fair, they did sort that out, and she has healed. So most of our patients who come back from abroad have had aggressive liposuction and skin excision and come back with infection or enormous wound dehiscence or big seromas, which we then, because there are acute problems, we end up sorting out on the NHS. We've had one with necrotizing fasciitis, actually. So it does happen. In terms of advising them what to do and what not to do, I think that if they're desperate to have the non-abdominal stuff, which we don't fund on the NHS in Coventry, then I think it would, for me, I don't think I've actually had to do this actually, but the sort of things that I would say are, you need to make sure that the surgeon is not going to promise you something you can't have. The scars aren't going to be long. Don't go for perfection, and make sure that you are not a smoker. Diabetes is controlled. You're not carrying a lot of excess weight, because those are the risk factors for problems. And look at what aftercare that they're going to provide you with.
And with regards to seeing patients pre-op, and they always ask in the clinic, or how much excess skin am I going to have? Yeah. What would you say would be the advice to us in terms of who do you think's more at risk, etc.? Who's got more chance? Who's going to do better? Who's going to do worse? So
do you mean in terms of
pre-bariatric surgery? They're addressing their concerns pre-bariatric surgery of, I want to go through with surgery, but I'm really anxious about what's going to happen with my skin afterwards. Is it going to be bad?
Yeah. So I mean, bad is you know, is in the eye of the beholder, isn't it? Really. I think you have to say to patients that there's the high likelihood you're going to have a lot of extra skin, and depending on where you live on the country, depends on whether or not you're going to have to pay to have it removed or not. And that's the reality of where we are.
Okay, and perhaps last question. So those patients who only have a small amount of skin and maybe can't access, are there any non-surgical treatments out there?
Not really. No. Once the skin is loose, it's loose. Sometimes do see patients who put themselves in for a liposuction consultation who have loads of skin, and there's no point, because all liposuction does is makes the skin even looser. And then because it has been so stretched up with weight gain and then dramatically loosened with weight loss, there's nothing that really can help that isn't surgery that will tighten that skin, only excising the skin.
So perhaps one last question for me. Can you just explain what you meant by resuspend the fascia as one of your 4 stages? I didn't quite understand that.
So particularly if you're doing circumferential, like belt-like lipectomies and things, you divide, you dissect down through the superficial and down to the deep fascia and excise the skin, and all the skin then will drop. If you imagine them standing up, the skin will drop, nothing's hanging onto it. So I take 2 PDS and I get big bites of the fascia, and I lift it up, bite into the deep fascia, bite into the top incision to try and suspend the buttocks and the thighs so that they don't drop. And it helps to close the wound, obviously, but it gives that a bit of a lift. So the problem with any lifting operation is gravity always wins. It's going to go down again. So if you are going to try and do a lift with an excision, you've got to resuspend the fascia. You've got to stitch the fascia back on again. You've got to put the lampshade back onto the lampshade frame, yeah, because it's melted off, like in that analogy. So that's what I meant by that. You have to lift up and stitch the fascia to get lots of points of adherence, loads of stitches, so it all sticks where you want it and it stays there.
Well, it looks like, you know, judging by the number of questions we've had a great deal of interest in your talk, Matt. Thank you. So I think one of my take-home messages is to tell my patients perhaps to move to Coventry, and then they might qualify. So you may find an influx of patients moving into your area. So thank you again for giving up your time and giving that excellent talk, very informative. A reminder for those of you who weren't here at the beginning that the next journal club will be on the 12th of April, and the next educational webinar is the 26th of April, and BOMSS will be sending out the details of those closer to the time. So without further ado, thank you again, Matt, for your talk, and good night to everyone.
Thank you very much. It's been a pleasure.
Take care. Cheers, Matt and Matt.
Okay.